Hey everybody, Dr. Smith here. Just wanted to go over tracheostomy management and care so that we can provide the best care for our patients in the field. So what is a tracheostomy? So there's actually two definitions and two words that we use interchangeably commonly. First off, tracheostomy. That actually refers to the surgical hole that's placed in the trachea. The tracheotomy itself is the procedure that's done to place that hole. However, in medicine, we often use these two terms interchangeably. It really doesn't matter. And in fact, we often use these terms to indicate the actual device itself that is placed in the hole to help to facilitate respirations. So there are many different types of tracheostomy devices that come from several commercial suppliers. Luckily, there are common features across all devices that we use. In this picture on the screen, you can see there's an outer cannula, there's a line with a balloon to help you inflate the cuff. There is an inner cannula, an obturator, and a plug. You'll see different shapes and colors on these, but most tracheostomy kits will have these essential components. There are also many accessories that go on these tracheostomies. They include passive Ure valves, the purple product that allows you to speech. They include guards that help to prevent dirt or other debris from entering the trachea, and they include heat and moisture exchangers to help to prevent the airway from drying out. So why do we do tracheostomies? The first indication is just to bypass obstructions. So if we have stenosis of the glottis or the supraglottic space, oftentimes that can lead to airway obstruction, and we have to do tracheotomies. Sometimes there are cancers, masses, strictures in the airway that prevent the patient from being able to either breathe normally or even be intubated. Sometimes we have to do constant pulmonary treatments, it's called pulmonary toilet, and if we have to do those long term, oftentimes it's indicated a tracheotomy for easier access. Sometimes a patient needs prolonged oxygenation or ventilation, such as with a C-spine injury when they're paralyzed. And sometimes we do it to protect from aspiration, especially in elderly or patients who cannot protect their airway due to head traumas or chronic neurological conditions. So I wanted to dive a little bit deeper into prolonged ventilation. That's probably one of the most frequent reasons that we have to place tracheostomies in the surgical setting. So what happens to our diaphragm or our body as we are on a ventilator long term? So a group of scientists in 2015 actually studied this, and they looked at 54 patients that were ventilated for at least 3 days. They used ultrasounds to measure the diaphragm thickness to assess for diaphragm dysfunction. Now, if you look at this picture, you'll see that most of your diaphragm is just connective tissue in the middle, that white part. The actual muscle that helps us to breathe is only a thin rim around the outside. So any loss of that can lead to a decrease in your ability to take a deep breath. What this study found was that at 24 hours on the ventilator, there was a 9% decrease in the thickness of the diaphragm. At 48 hours, it had decreased 20%, and at 72 hours, it had decreased a quarter of its thickness or lost a quarter of its muscle mass. There was no significant change after 72 hours, so it seems to be that's where the diaphragm stopped thinning out. So what this study kind of confirmed was that after about 1 to 3 weeks on the ventilator, the diaphragm is often too weak to help to provide spontaneous ventilations, and we have to consider providing a tracheostomy to help this person breathe long term. So how do we actually place a tracheotomy? The procedure is pretty simple, and it often involves a Seldinger technique, which is usually a needle and a guide wire. Oftentimes we'll use fiber optic bronchoscopies to look inside the trachea while the external trachea is being manipulated. There are any number of proprietary kits, but most are fundamentally just simple scalpel, needle, tube. The location is actually different than where we do our surgical crikes. It's usually between the second and third tracheal rings, a little bit lower on the neck. Oftentimes you'll see it right up here above at the tracheal notch. So what are the signs and symptoms of a tracheostomy issue? Oftentimes it's the same signs and symptoms that we see for any of our respiratory patients. Hypoxia, increased work of breathing. Maybe if you are assessing the tracheostomy itself, you're unable to suction it out, you can't place the inner cannula. Perhaps you notice some bleeding or swelling around the site. Those are the most common signs and symptoms that we'll see with our tracheostomy patients. So when we're talking about complications of tracheostomy, we really split them into 3 categories. There's immediate, short-term, and long-term. Immediate, we will rarely see. Those are often done in the surgical setting or in the hospital. These include paratracheal intubation, where the tracheostomy actually goes into the tissue, not into the trachea itself. You can also have damage to the posterior tracheal wall. Again, very likely to be seen pre-hospital. Short term is up to 7 days from the placement of the tracheostomy. This includes bleeding. You can accidentally dislodge the tracheostomy or accidentally decannulate it. You can have localized infections or pneumonias, loss of the airway just from the tissue being so angry and irritated that it can actually collapse. You could have subcutaneous emphysema or air underneath the skin, and you could aspirate or have foreign bodies enter into the lungs. Long term, at 7 days and longer, we're talking about usually years, but can be seen as short as a few weeks. But tracheomalacia, where the trachea actually becomes very floppy and can collapse on itself. Tracheal stenosis, where it narrows down. Tracheoesophageal fistulas, get a hole between your trachea and esophagus, very dangerous. One of the most dangerous ones that we'll talk about in a bit is tracheoarterial fistula, erosions, vocal cord paralysis, or delayed stomach closure. So many complications, but knowing the timing usually will help you decide which ones to worry about. A little side note, here's a very, very rare complication that I hope we never see, but there is an airway fire. So some anesthesia agents are extremely flammable, and oftentimes in surgical procedures they will use electric cauteries that can spark. So this was actually from a case where a tube caught on fire in the patient's lungs during surgery, and the actual study said, quote, a bronchoscopy was performed immediately, showed black carbide covering the area from the trachea to the main bronchi. So unusual, but it can happen. So when we're assessing our patients with tracheostomies, history is key. So the very first question you should ask, and probably the most important one, is when was the tracheostomy placed? Other questions that we need to know are, what were the indications for the placement? Are there any recent hospitalizations or infections? What medications are they taking? Especially, are they on any blood thinners? Are there any signs of bleeding? And are there any ventilator alarms or signs that the patient is using increased oxygenation or respiratory support? So when you're assessing these patients, the most important thing you can do is protect yourself. Tracheostomies can get very, very messy with mucus, blood. Always protect yourself. Consider common complications: displacement of the tube, obstruction, equipment malfunction, bleeding, infection. These are the things we're going to see time and again. So you're getting ready to assess a patient with a tracheotomy. What kind of equipment should you have ready? Well, it's common airway devices, especially PPE. Suctioning devices, you want to have a spare tracheotomy device. We don't carry these, but oftentimes the families will have them, and in fact they should have multiple devices of different sizes available. And this is one of the things they're trained on before the patient leaves for home. You also want to have rescue devices such as LMA. You want to have endotracheal tubes. You want multiple sizes, usually from a 6 to a 7.5, even smaller for our pediatric patients with tracheotomies. You want to ensure capnography and bougie as well. So the first step in assessing your patient with a tracheostomy is to assess the breathing. Look, listen, feel for signs of breathing. Check the upper airway and tracheostomy site for at least 10 seconds. Use end-tidal CO2, including the waveform and the amplitude, and also assess pulse ox. Very similar to our standard patients when you're assessing their respiratory status. Once you've established all your equipment is ready and you're actually assessing the patient, you want to use a methodical approach. Personally, I like an outside-in approach. I look at the external devices, the oxygen sources, the ventilator itself, before I ever move on to the patient. Make sure that the equipment is functioning before we actually assume that the tracheostomy has failed. So when you've prepared yourself to manage the patient, here's a stepwise approach for managing tracheostomies. Number one is to provide supplemental oxygen passively. Apply 100% FiO2 to both the face and tracheostomy site. Number two is remove the inner cannula of the tracheostomy. Now this device should be easily removable. If you have any issues with it, stop immediately and talk to the patient or a family member that is there. Number three, once the inner cannula is removed, attempt to pass a suction catheter through. See if there's a blockage, maybe a hardened piece of phlegm or mucus. If you cannot pass a suction catheter easily, or if the end-tidal waveform is low or absent, deflate the cuff and remove the tracheostomy tube. Use caution here. You must know when the tracheostomy was placed. This is critical, and we'll talk about that a little bit more later, in a very dangerous complication. Step 5 is assess the upper airway. If it is patent and you've had to take out the tracheostomy, you can use a bag valve mask, supraglottic airway, or endotracheal tube to intubate the patient. Going back to what we said earlier on the history, knowing why the patient has a tracheostomy is key. If the patient has a blind airway, such as if they've had a laryngectomy for head and neck cancer, you're not going to be able to pass any kind of tube or get air because now the entire trachea has been healed over at that level. If the airway is not patent, so again, you have a laryngectomy, use a pediatric bag valve mask over the stoma or number 2 LMA to try and get a seal around the stoma to use a bag to ventilate. If it's a pediatric patient, use the smallest LMA or face mask that can fit over the stoma. In extreme circumstances, if all else fails, you can do mouth to stoma resuscitation. I do not recommend this, especially considering the amount of mucus that can be involved, but it is a last-ditch effort, so consider this if you so choose. If a patient has a patent upper airway, you must hold the mouth and nose closed in order to bag over the stoma. Remember that. Otherwise, you have air going down the lungs and out the mouth. You're not going to get the pressures you need. Also use the highest pressure settings you can set on your bag and use a PEEP valve if available. Now it's time to replace the tracheostomy tube or intubate the stoma. This is where knowing the age of the tracheostomy is absolutely critical. The tract is not considered healed and matured until 7 days after it's been placed. So if the patient's only had it a few days, there is a very high risk that putting an endotracheal tube through the stoma could end up underneath the skin and the patient could suffocate very quickly. If the tract is at least 7 days or older, you are totally safe to go ahead and try to replace the endotracheal tube by hand. There is no absolute endotracheal tube size. You really can use whatever you can get to the stoma. Usually a very small one around a 6, like we mentioned, is helpful. A bougie can be very helpful, especially if you have to replace the tracheostomy for like a balloon rupture, where everything else is fine, we just need to keep the tract open. Now, you can still attempt a blind insertion at less than 7 days if it is an absolute last-ditch effort. However, at this point, all other efforts should have been attempted and online med control should be involved. And your last step in assessing the tracheostomy is looking for alternate causes. Pneumonias, foreign bodies are routine causes of respiratory distress that we see every day. Let's talk about some other tracheostomy complications besides just airways and hypoxia. The most deadly complication of a tracheostomy is a tracheoarterial fistula. This is a true emergency. You may also hear it referred to as a tracheoinnominate fistula. This is an abnormal tract from the tracheal artery, which is just below the skin about right here, that can actually erode into the trachea and bleed into the lungs. Now, it only takes about 200 cc's of fluid to fill your airways and drown in your own blood, so it can be, with the arterial bleed right here into a trachea, very, very dangerous. 0.6 to 0.7% of patients with a tracheostomy will experience this. It can occur as soon as 30 hours after placement, but it can even occur years after. So if you ever see any bleeding, always keep this in your mind. 70% of bleeds occur early, actually within 3 weeks of placement of the tracheostomy. Luckily, there are some warning signs, and about 50% of the cases, they have what we call a sentinel or herald bleed that self-resolves. So you will see reports of a little bit of blood around the trachea, but it stopped bleeding, patient's fine. This should really get your warning signs up that this tracheoarterial fistula could be imminent. Usually the sentinel bleed will occur 24 to 48 hours before the major bleed. So we've already been over the warning signs of a tracheoarterial fistula. Let's talk about why it happens. When we have this cuff inside the trachea that's inflated, if it's inflated too much, it can actually cause a pressure ulcer to form on the anterior surface of the trachea and eventually eat into the tissue and eventually the artery. Mostly it's the innominate artery on the anterior portion of the trachea, but it can extend into any arteries around the trachea, even into the aorta posteriorly. It's much less common in uncuffed tracheostomies, but it is still a potential issue. It is a very high mortality. Up to 80% of the people that have this spontaneously will die. Untreated, 100% will die. So if you see this, you must intervene rapidly and transport quickly. So we can see in this picture the relationship of the aorta and the trachea, and the innominate artery usually comes off the aorta or one of its first branches. It usually crosses the trachea at the 6th to 9th cartilage ring. It's lower trachea. Usually the lower it crosses is a higher risk of bleeding. There are several things that happen to people throughout their life that can increase risk of bleeding, such as long-term use of corticosteroids, radiation to the head and the neck, recurrent episodes of low blood pressure causing tissue ischemia. Any of these can increase your risk for a tracheoarterial fistula. So how do we manage a tracheoarterial fistula? First off, prepare. Just like any other massive hemorrhage, establish 2 large bore IVs, IOs if necessary. Prepare for airway resuscitation, supplemental oxygen, all of your equipment, suctioning. Prepare for intubation. Again, this is the same issue. If we've had loss of the airway, we can still intubate if they have a patent airway. Prepare for hemorrhage and protect yourself. Contact the receiving facility to give them a heads up. They may want to prepare the emergency room, operating room, or activate mass transfusion protocols, notify their anesthesia, etc. So now we're ready to actually manage this patient's tracheoarterial fistula. If they have a cuffed tracheostomy tube, overinflate it. I know I said earlier that overinflation might have led to this issue. However, in this case, we're actually going to use the increased pressure to hopefully tampen out off the bleed, just like putting pressure on arterial bleed on a limb. If the tube is uncuffed or if the overinflation fails, you want to first intubate orally, then remove the tracheostomy. Do not risk losing the airway. Intubate prior to tracheostomy removal. If there is a blind airway, like if they've had a laryngectomy, go ahead and insert an endotracheal tube through the stoma after tracheostomy removal. You can use bougie assistance if indicated, because at this point we're not worried about obstruction, but a bleed. You want to make sure that the balloon is distal to the bleed to make sure to protect the airway. If the balloon is either compressing the airway, compressing the bleed to help protect the airway, or distal to the bleed where you can inflate it and block blood from going down, then you've helped to secure this airway. So there is a maneuver we can do at this point. Up to now, we have secured the airway. We have either intubated orally, or we've placed a tube beyond the bleed, or we've blocked off the bleed with a cuff. Well, if all of that's failed, what else can we do? There's still the issue of the bleed. It's an arterial bleed. The patient could lose a significant amount of blood. You can actually perform what's called the Utley maneuver. What it is this picture shows to the left. You insert your finger through the stoma, hooking it around so you can actually pull forward and apply pressure anterior to the chest. So from the side, you would actually go in, hook, and pull this way. What your goal is to provide direct compression to that arterial bleed. After this, transport rapidly. So if you have a blind airway and a tracheoarterial fistula, you want to secure the airway by passing a bougie, an ET tube, or ET tube directly through the stoma and performing the Utley maneuver as prescribed below. The difference is now you want to go ahead and actively press around the stoma to provide as much passive oxygenation as you can with a mask. How do we tell if there is a tracheoarterial fistula? When you arrive at bedside, look for bleeding. If a patient had a sentinel bleed but is not actively bleeding, monitor very closely, but do not remove the tracheostomy. You should intervene immediately if you see evidence of an active bleed, especially if you see an active arterial bleed. Let's talk about some other tracheostomy complications. First off is infection. They can present with slight bleeding, again, not tracheoarterial fistula, but always wonder if this is a sentinel bleed. They could also have obstruction of the tracheostomy, fever, cough, shortness of breath, the common things we see with a respiratory infection. Infections could be localized to the skin like a cellulitis. They could have infection in the trachea, tracheitis. Unfortunately, it could present even worse and have an infection at the middle of the chest around the heart called mediastinitis, which is very dangerous. Or they could have a general pneumonia. Treatment is very easy. Ensure the airway is patent. Provide normal concern for infection care, antibiotics, fluids. Treat it as we do our sepsis patients. Unfortunately, whenever you have a tracheostomy, all do require IV antibiotics and will need to be admitted to the hospital. Another complication would be a stoma bleed. Usually these are due to infection or irritation of the stoma site. Treat these with routine wound care. Again, all stoma bleeds considered sentinel or harrow bleed until proven otherwise. There are other complications that can arise from tracheostomies. Tracheal stenosis is one that we see quite frequently. It often occurs at the level of the stoma and below the cords, usually as a result of a bacterial infection and chondritis, which can weaken the tracheal walls and cause them to scar down. Often we don't have any symptoms until the tracheal lumen has reduced by at least 50%. Treatment is supportive and will need surgical intervention. Again, this is one of the things that could progress to a blind airway. Another common complication is tracheomalacia. Usually this is from destruction and necrosis of the supporting cartilage. Basically, the airway gets very floppy and can kind of collapse down in on itself. Its treatment is supportive care. If you're unable to ventilate, consider endotracheal intubation and pass the ET tube past the area that is concerned for being weakened and flopping down. The final tracheostomy complication we see frequently is subcutaneous emphysema. This looks pretty scary, but it's not dangerous at all. This is actually leakage of the air into the subcutaneous tissue, and it causes the skin to balloon out. And actually, if you press on it, it feels very crackly. I always tell my med students that it feels like Rice Krispies sounds. This is not a dangerous thing. Treatment is supportive. There are some surgical procedures that can be done to help if it is extensive. However, most of the time this will resolve on its own within a few days. So this slide is a picture of subcutaneous emphysema. You can see along the sides of the chest wall and around the neck there is significant amounts of air underneath the skin. Again, looks terrifying, however, totally fine. Not dangerous at all. Thank you for your attention, everyone. Just wanted to go over a few key points for tracheostomy care. Number one is the tracheostomy tract matures after 7 days. Before this, blind placement is strongly discouraged because you could put it underneath the skin and the patient could suffocate. Any bleeding from the tracheostomy site should be considered a tracheoarterial fistula or sentinel bleed and is considered a surgical emergency with exceedingly high mortality unless proven otherwise. If you cannot ventilate through the tracheostomy, remove and intubate orally or through the stoma. Thank you, everybody.